Now I have the distinct pleasure of inviting Dr. Mohammad Hirzallah, who is setting himself up as a optic nerve sheath diameter expert, and he will talk to us about ocular ultrasound and how we can use that in evaluation of intracranial pressure. Thank you, Mohammad, for joining us.
Yeah, thanks for having me. And share screen. All right. Well, good morning or good evening, everyone, depending on where you are. I'll talk to you about ocular ultrasound today. We will talk about my favorite topic, ONSD, and then we'll do a little bit of papilledema, Terson syndrome, and pupil reactivity. As many of you know, the subarachnoid space of the optic nerve sheath is continuous with that of the brain. So theoretically, changes in intracranial pressure without communicating cerebrospinal fluid columns should make it act like a barometer. And we have some experimental studies that looked at this. In this study, they inflated a balloon in a monkey brain, and a few things were noted. If you inflate it too fast, the brain would herniate and the monkey would die. But if you inflate it slowly over days, you would get both papilledema and optic nerve sheath distension. And if you inflated faster than that, you would get only optic nerve sheath distension without papilledema, which tells us what we know, that papilledema is a finding seen with chronic ICP elevation. Another interesting thing they did was they fenestrated one of the sheaths, and that resolved the papilledema. This is a cadaveric study that transduced ICP from both the ventricles and the optic nerve sheath and showed a direct correlation between the two. So now, knowing what we know, this is how you perform the measurement. A linear probe placed on the like a lateral axial view, so on the upper eyelid, outward a little bit, and you try to line up your image with the optic nerve sheath and with the black meets black mnemonic, so basically the thinnest optic nerve interface. So this is what your image ideally should look like. That's the optic nerve and your eye, and the dura, the optic nerve sheath subarachnoid space, and the retroorbital fat. And this is what your optic nerve sheath diameter measurement should look like. Now, the devil is in the details, as always, and there is a little bit more nuance to this measurement. So one of the most important ones is that, and you'll see this repeatedly in the literature, is that people don't distinguish between the internal and external measurement, basically whether or not you include the dura or you include just the subarachnoid space without the dura. And these measurements can be very different. The difference can be up to 1.5 difference, and that's statistically significant. So if you consistently measure internal in some patients and external in others, you will have a positive study for whatever you're looking for without actually having a distension. They both had similar sensitivity and specificity for detecting elevated ICP, so that it's important to know that it's okay to use either. So whichever one you use consistently. And when we look through the literature, most the studies we looked at, 86% did not specify whether they used internal or external. There's a lot more detail to this, and this is something we published with many of our friends in the panel today. And it's basically a checklist that goes through imaging and measuring ONSD step by step. So I recommend that you look at that. For a 10-minute lecture, we should not go into that level of detail, but if you're interested in ONSD imaging, I recommend that you go back and look at this. Another thing that is not discussed often is the importance of ultrasound settings and artifacts in measuring ONSD. So I'll give a few examples. If you guys are interested in seeing more, you should check that manuscript out. This is, for example, what changing the dynamic range does to your image. Think of it like the Hounsfield units on a CT scan, or your windowing on a CT scan. So changing your dynamic range can change the number of shades of gray that is presented to you and can make the boundaries of the optic nerve sheath clearer. Another one that people don't pay attention to sometimes is the effect of ultrasound focus. We think of the ultrasound beam as linear rays, but in reality, it's more like an hourglass-shaped beam. And your focal zone is going to have the highest resolution in your image. So a lot of the time it's expressed as these two X's or brackets or arrows on the side, and you can move it. So moving that focal zone to your area of interest would increase your resolution. Another one is volume averaging artifacts. So if your image is off axis, you will end up combining the echogeneity of different structures. Like this is a combination of retroorbital fat, optic nerve sheath. Ideally, you want to be lined up exactly with the nerve so you can get the measurement you're looking for. Acoustic shadowing is another one. If this mostly happens if your image hits the optic nerve head at an angle, causing some either refraction artifact or shadowing artifact, and you get this black structure that is not really there. Okay, so that was it for optic nerve sheath diameter. I might be going too fast, so probably Artie's happy with that and getting you guys some time back. Papilledema is, as we said, it's more of a chronic finding. We don't typically see it in acute ICP elevation. It's prevalent in things like idiopathic intracranial hypertension. The mean values is 0.6 to 1.3 millimeters. It's useful in addition to optic nerve sheath diameter and chronic disease processes. And this is what an optic disc elevation versus normal normal retina looks like. This is a study that graded the B-mode ultrasound papilledema in pediatric patients, mostly doing it by number. So grades 0 and 1. So 0 is essentially normal, 1 slight elevation without edema, 2, 3, and 4, you start seeing some edema in the optic nerve head. And once you cross around 0.53, so grade 2 here, your predictive value, or your positive predictive value for ICP goes much higher to 90%. So if you see this, your positive predictive value for elevated ICP is pretty high. Another ocular finding that is associated with elevated ICP is Terson syndrome. So Terson syndrome is ocular hemorrhages that are classically reported in subarachnoid hemorrhages, incidence between 12 to 28%, but it's also seen in other causes of acute elevated ICP, subdurals, traumatic brain injury. It can include retinal, pre-retinal, or vitreous hemorrhages, and those are some examples of what it looks like on fundoscopy. This study compared the diagnostic performance of ultrasound and CT to fundoscopy, and ultrasound should not be too surprising, performed much better than CT scan because we have higher resolution with the linear ultrasound. You'll see that for vitreous and retinal hemorrhages, our sensitivity and specificity were 100%. It's retinal hemorrhages where the sensitivity dropped, but the overall sensitivity is 74%, which is good. Positive predictive value, 100%, negative predictive value, 94%. So pretty good numbers for ultrasonography, but not the same with CT scans. And this is what it looks like. So you see a vitreous hemorrhage here, pre-retinal hemorrhage here. And this is what it looks like on CT. Obviously, much higher resolution, higher image quality with ultrasound. B-mode pupillary assessment. This is what it looks like. So you you place your probe with this kind of coronal view, usually below the eye, aiming up, so you can go through the pupil, and you either shine a light on the other eye or try to shine your light through your eyelid, and you can perform the measurement with your caliper. This is the classic case of when this measurement would be useful. Someone with a swollen shut, with an eyelid swollen shut, where you can't open the eyes to do your pupillary assessment. That can be helpful there. And this is an example of doing the measurement with M-mode. So you can measure your diameter through this thick hypoechoic area that is your pupil. So you can have the change over time. And that is it. That is all I have for you guys today.